right. So happy Tuesday and welcome to the last hour of this 2-day epilepsy event. I am going to talk about functional seizures or psychogenic non-epileptic seizures or events. I'm Maija Steenari. I'm one of the epileptologists at CHOC. We see quite a bit of kids or children with non-epileptic events. And this is very important diagnosis to make so then we can treat the kids appropriately. So I'm going to concentrate on pediatric population, but obviously this diagnosis is very common on adult patients as well. So I'm going to give you patient examples to kind of help guide us through the diagnostic workup and treatment for these patients, and kind of highlights some challenges that we often have when we see patients with non-epileptic seizures. So my patient one, she is 14-year-old right-handed girl. She has chromosome 6q duplication syndrome. She has some cognitive impairment. She has epilepsy. She has some cardiac conditions, some kind of bowel and bladder symptoms secondary to tether cord. And she comes into our ER with breakthrough seizures. So when we go and see this patient in the ER and ask mom some further details, mom tells us that, she has all body shaking. The seizure lasted about 1.5 minutes. And now she's back to baseline. And then when we ask about, well, is there any other types of events that you're seeing on your child? She also describes episodes of the girl complaining brain hurting and someone poking her brain. So these are also considered seizures. Mom calls them partial seizures. Prior coming to the ER today, she has been seizure-free 1 year. So previous seizure was 1 year ago. She also, when we always kind of go into detail on, well, can you describe, is she doing this and that and whatnot? And when we talk about staring spells or kind of events of behavioral arrest, mom also says that she has events of kind of daydreaming or staring, and then she goes into these whole body shaking seizures. When we go and kind of look back on her medical records, and we ask more details on seizure history, we learn about her having first seizure when she was 1 year of age. At the time, the seizure was described as bilateral shaking, and she had been started on phenobarbital at the time, and she was seizure-free for 4 years. And at that time, phenobarbital was discontinued. She was doing fine. So between ages of 5 to 12, she was doing fine, no seizures, and then she presented to emergency department at 12 years of age with generalized shaking. And at that time, she was started on anti-epileptics again, based on her past medical history and history of epilepsy. When we look back on her studies that we do for evaluating seizures, we noticed that her initial EEG when she was 1 year old was normal. She had a normal EEG at the time when phenobarbital was weaned off. And then she had a normal EEG at the time when she presented at 12 years of age with breakthrough seizures. And then again, just recently over the past year, at the time when she presented, she had a normal EEG. Now we know that normal EEG in between the seizures doesn't rule out epilepsy. But that's kind of interesting that, you know, she has multiple points of looking into her brain waves and all of these time periods her EEG has been normal. So what do we do in this situation? We typically start doing further investigations to make sure that we are treating what we are thinking that we are treating. And in order to diagnose specific spells, we typically like to do a long-term video EEG monitoring to capture these events. And there she is in our hospital bed. She is eating. And mom is sitting on the left side of the bed. I apologize, the blue bar on the face, but that's just for privacy. So she starts having right arm shaking. Her head is turned to the mom and she's looking at the mom, and mom is pulling the tray away. And mom is asking her a question. So you notice that the arm shaking is kind of irregular. So it's not rhythmic, it is arrhythmic, and it stops, especially at the times when mom is asking her a question, and then it starts again. And this continues, and now mom is talking her more, and then the shaking starts again, and the shaking is more kind of on the distal part, so on the finger wrist part of the face. Of the arm, and that's it. And there was the full body shaking that you notice, so like a quick body jerk, and then there's a little shaking of the legs as well, and then she kind of passes out or closes her eyes and falls asleep. So throughout this event, we captured multiple similar events. Mom said that these are her typical seizures. Her EEG was normal. Then we go to patient 2. Patient 2 is an 18-year-old young female, young lady, and she only has a recent onset of epilepsy. So she has events described as just kind of abnormal body movements, hand smacking. Mom describes the movements as hand smacking. She also has whole body jerking. And initially, these events started about 4 months prior to presentation. At the same time, she also started stuttering. And then recently, they have been increasing in frequency and currently occurring several times a day. She also has some complaints of foot pain, hand pain, kind of describing as I feel like pins and needles sensation. And sometimes these pins and needles sensation on the foot and hand evolve into including her abdominal muscles, and she actually has kind of spasms in her belly. And that a few physicians had tried to treat with muscle relaxants unsuccessfully. And then just recently, before she came to us for evaluation, she started having 1 to 5 minute long episodes of shaking and jerking of arms and legs. She actually hurt herself a few times. And she would also cry during the events. She was describing of feeling hot. She was kind of seeing or hearing things, and she would mumble words during these periods of time. But she was slowly able to follow commands during the episodes. Sometimes these events were triggered by feeling upset. Sometimes certain sounds might kind of trigger an event. And when we ask kind of details, what happens first, what do you feel first? Is it a sensation, or do you see something, hear something, do you feel something? She often felt like she's been feeling kind of a higher temperature and feeling hot before the event starts. She also started having episodes of passing out after these events. And sometimes she was even falling down. But often when we asked, if she hurt herself with the fall, often mom was there next to her catching her, and she didn't get hurt. She does have a history of anxiety, and she had gone through evaluation in 2 large medical centers prior presenting to us. And she had been tried on 3 different anti-epileptics without cessation of these events. So if you talk specifically about epilepsy, at the time when you fail your second anti-epileptic medication, we start talking about medically refractory epilepsy. So she was definitely at the point where we needed to see what's going on in order to treat her appropriately. So she was also admitted to our EEG monitoring unit, and several typical events were captured. So oftentimes when we get the details from the patient or from the family, even though we describe of like right arm or left arm shaking or bilateral shaking, with an epileptic seizure, that moment might be different. Here you see she has kind of very irregular shoulder and leg jerking movement, flailing of the arm, and then kind of all body flailing in an arrhythmic pattern, and then she passes out after, and she actually remains non-responsive a longer period of time after the seizure. But throughout the event, again, the EEG remained normal, and there was no concern for epileptic activity. So both of these patients were diagnosed with, the old word is Psychogenic Nonepileptic Seizures, or PNES. I'm going to use that term because it's more known as recently, for example, functional neurological disorder, FND, has been used as well. But these are events that there's discernible changes in behavior or consciousness, and the events look like epileptic seizures, but they are not associated with electrophysiologic changes. So that means the EEG remains normal. There's no spiking activity or changes on the EEG that is concerning for epileptic fetal activity. These psychogenic non-epileptic seizures are defined as a change in behavior. As I said, that they look like epileptic seizures, but they have a psychological origin. And nowadays they're categorized as manifestation of conversion disorders. These events represent a symptom, and they're not an underlying disease. And the mechanism of this dissociation is pivotal in the pathophysiology. And whenever we make this diagnosis, it's very, very important to look into factors in this particular case that we have to see what's going on and what the correct management and treatment is. And why do we want to know? Well, it's very important to make this diagnosis because patients with non-epileptic seizures, they actually utilize a considerable amount of medical resources. For example, going to the emergency department, they get hospitalized for refractory seizures, they get frequent physician visits, and then often are treated with unnecessary medications. There are some studies showing that kind of treating a patient with non-epileptic seizures that is kind of wrongly diagnosed or undiagnosed, the cost, a lifetime cost for treating these events is about the same as lifetime cost of treating epilepsy. So several $100,000. I think nowadays it's way more than that. This sum was from 1995. So absolutely the medical field is more expensive at this point. So there are some key symptoms that we, when we get the history of the event, or if we see a video of the event, or if we see a patient having a non-epileptic event that can clue us to either, yes, this looks like an epileptic seizure, or this looks like a non-epileptic event. So often epileptic seizures are quite short, actually. They last about 30 seconds up to a minute or two. What's quite classic on non-epileptic events that they just kind of linger longer time, 5, 10 minutes, 20 minutes. I've even had some patients going on 45 minutes of these events. Pelvic thrusting is actually quite rare with epileptic seizure. So what that means is kind of the middle of the body moving up and down on the bed. It is used as one of the kind of key markers or hallmarks on non-epileptic seizures, but it's actually not always happening. So you don't have to have that with the non-epileptic event to be diagnostic. Epileptic seizure, the eyes are often open. It's quite common that with non-epileptic seizure, the eyes are closed. Same thing with the mouth. And especially like if we go and check the pupillary reflex with the light, there's often a kind of a forceful eye closure during the non-epileptic event. Side-to-side head movement is quite rare with an epileptic seizure, but sometimes or more commonly happening with non-epileptic event. Actually, patients with non-epileptic seizures can bite their tongue, so it does not rule out either or, even though we do ask this as one of the history questions when we see a patient with seizures, if there's a tongue biting or not. Crying during the attack is quite rare with epileptic seizure, but we've seen it. It's more common with non-epileptic events. And sometimes, even during an epileptic seizure, patients may be able to talk more commonly, with non-epileptic event. If there's no kind of period of loss of consciousness, the patients are able to talk during a non-epileptic event and maybe follow some commands. Sometimes the speech is kind of slurred or it's slower, but they often are able to answer some questions. This is kind of the classic a photo of non-epileptic seizure, or it was called hysteria in the 1800s. Now, kind of that back arching, stiffening position was thought to be classic with non-epileptic events. That being said, we do see this kind of a moment sometimes also with epileptic seizures. So it's not a hallmark of non-epileptic events. So what are physicians thinking? If we see a patient with non-epileptic events, kind of what comes to our mind as far as characteristics of the events, or what do we start thinking about as far as the kind of the reason for somebody for having non-epileptic events? So kind of psychosocial stressors or trauma comes to mind. Sexual abuse is out there in the literature, but especially in pediatric population, it's actually not very common cause. So it doesn't have to be a very severe, significant psychosocial stressor or trauma that causes non-epileptic events. Sometimes it can be just a kind of a high achieving young child or adolescent, kind of a stressful schedule, go all the time. And then, we can't tease out any specific trauma in the history, but kind of that inability to process stress and maybe anxiety or whatnot, the body starts producing these events that look like seizures. It doesn't always have to be kind of a very something harmful or traumatic that has happened. What's very common is anti-epileptic. We throw them in the mix, and the events continue despite the medical treatment. And then there's some event characteristics that are associated with non-epileptic events, like resisted eyelid opening. So they resist when we try to open their eyelids. Kind of the classic is we learn during medical school that when we lift the arm above the head and let it drop over their face, they kind of save their face and the arm doesn't fall on the face where they can hurt themselves. These events often happen more frequently when others are present to see them, and rarely there's injury related to these events. And often once the event is done, the patient is right back to baseline, so there's no post-expo slowing. There's some key features on the pediatric population in the presence of non-epileptic events compared to adults. First of all, very young children can have non-epileptic events. Depending on the author you read, sometimes some authors say as young as 6, and we've seen even younger than that. On the adult side, female gender is more common as far as in the population of this diagnosis, but as we get to younger ages and younger children, we have boys and girls, same ratio. Also, with our younger kiddos, they often have also epileptic seizures, so they carry the diagnosis of epilepsy, and they do have EEG confirmed epilepsy as well, but then they can have non-epileptic events on top of that, and that's more common on kids. Often kind of family dysfunction is one of the stressors, but it doesn't necessarily have to be. And there could be either family history, so a family member who has epilepsy and then a sibling develops non-epileptic seizures, or other kind of psychiatric disorders in the family, like anxiety, depression, and so forth. The nice thing is children have much better prognosis for recovery on non-epileptic seizures than do adults. So that's why it's so important to make the correct diagnosis on these patients, so we can appropriately treat them and provide better recovery. So there was an article looking at what do these non-epileptic events look like. Some kind of key features that I took out from this article is the events, non-epileptic events, were much longer than epileptic seizures. Often the patients had an eyewitness, most commonly parent, present when these events happened. And then most of them, the events started abruptly and ended abruptly as well. Not very common with these kids was eye closure, so they have their eyes open. Also, about a third of the cases, the kids were unresponsive, so they don't always look like they're passing out. So how good are we? As an epilepsy doctor, sometimes we think like, well, we know what that event is, but we're actually not very good as far as either seeing it when it happens without having the EEG on the patient or looking at the video. We always ask you to videotape these events, but when there was a study looking at 23 videos capturing, either epileptic seizures or movement disorders or non-epileptic seizures, we, as epilepsy physicians, we were not very good. So only about 30% of the cases, the raters were able to make the diagnosis. So I personally do like to play the game of kind of making a guess if this is an epileptic event or not. But what I've noticed, my percentage of being correct is maybe 50% or so. So it's so essential to make a reliable diagnosis with video EEG monitoring. Because sometimes when we say, oh, that's a slam dunk non-epileptic event, we are wrong. Some kind of fascinating seizures that I've seen, I'm going to show one of them in the end of this talk. But for example, we had a patient who had chest hands, and that was her epileptic seizure. So we'll have to make our due diligence and make the appropriate diagnosis with appropriate diagnostic tools. So sometimes patients get injured with non-epileptic seizures as well. Kind of when they had done a retrospective database study looking at all the patients, almost 300 patients with non-epileptic seizures. There were surprisingly many who had actual body injuries like lacerations, tongue biting, even fractures, burns, dental injuries from falling, and whatnot. So it does not mean that if you get hurt, it's for sure epileptic seizure. And on the other hand, I think it's really important to make the correct diagnosis and treating non-epileptic events appropriately. Because if we just keep on throwing anti-epileptic medications to these patients and the events don't stop, they continue, it can be very, very harmful for them. For example, going to the ER with breakthrough events that are thought to be epileptic, ER doctor gives medications that we often use to stop seizures that are not stopping the non-epileptic events. And then these medications are not without side effects. They can cause cardiac issues. The patients can lose their respiratory drive, get intubated, and whatnot. And we've actually lost some patients with over medicating. So that's why the diagnosis is really, really important. It needs to be taken seriously. Unfortunately, sometimes us physicians, our attitudes towards functional seizures or non-epileptic seizures are not the best. For example, this study from Denmark from pediatricians or kind of pediatricians that were focusing on neurological disorders, about 20% kind of believe that the children fake their symptoms, which is not helpful at all. So more often than not, I hear the story on our patients that they go from ER to ER or physician to another, and kind of they just get the message, or, oh, it's in your head, stop faking it. And that's absolutely not the right way of approaching this diagnosis. What my message typically is to our trainees or docs or patients is, this is a serious and real problem, and we have to make the right diagnosis so that then we can treat it appropriately. For example, if you have a fungal rash and you put an antibiotic ointment on it, no matter how many different antibiotic ointments you put on that fungal rash, it's not going to get better, and you can actually kind of let it evolve and get worse. So making the right diagnosis and treating the patients appropriately, that's what they deserve. So how do we do the diagnosis? Well, as I kind of mentioned earlier, we'll do a video EEG monitoring. We'll capture these spells, and that's the gold standard. And then we'll also often have our psychology colleagues to do an assessment after we've made the diagnosis. And then sometimes we'll also ask help from our psychiatry. I was going to say fellows, but our friends in psychiatry to see if there's any other comorbid psychiatric diagnosis that can play a role in this. Before, on the DSM-4 era, non-epileptic seizures were kind of within their own, and they have their own diagnostic criteria, but now we use DSM-5 criteria, and non-epileptic seizures are lumped in the same category as functional neurological symptom disorder. So as long as some symptoms of the list are filled, and there's no other medical or mental disorder that can explain the symptoms, we can make the diagnosis. And sometimes patients have a combination of, so not only they have events that look like epileptic seizures, but they can have memory loss. For example, they can have weakness or even paralysis of body parts. They can have difficulty with walking or eating and whatnot. And sometimes these are lumped into the seizure-like event, but sometimes they're separate or ongoing. How frequent it is. I was actually looking a refresher on the literature, and we still don't know. It's actually quite difficult to tease out the numbers, how common it is. But it's estimated that of the kids who are within that umbrella of this patient has epilepsy, a little bit less than 10% of those patients have actually non-epileptic events and not epilepsy. When we started kind of teasing what other symptoms might these kids have, quite common, we see school-related difficulties or kind of stressful family environment or kind of conflict within that family environment. Sexual abuse is not as common as previously was thought, but it's still there. So we have to look into it. And sometimes we just can't find any kind of reason. We can find a stressor. We can find a trigger why these events happen, but they are happening. Most common comorbidities we see with non-epileptic seizures is depression or kind of separation anxiety, some panic attacks. So it's very, very important to address that underlying psychopathology in order to help these patients the best. So sometimes, throwing Keppra into the mix, we actually make things worse because the Keppra can worsen the kid's depression or anxiety and kind of trigger more of these events. So that's why the correct diagnosis is so important. So there is now a number of studies suggesting that cognitive behavioral therapy may be effective in the adult population. There is not very good studies in children yet, but absolutely very important is that very prompt intervention from a mental health professional who knows what they're doing to kind of get these kids better fast. Some kind of suggested or recommended therapies include psychotherapy, and sometimes it doesn't have to be kind of a very multi-step psychotherapy, but it can be kind of an explanation of what's going on, reassuring that this is not dangerous to your brain. And sometimes when we make this diagnosis and we explain to the family and to the patient what's going on and why this is happening, the events actually resolve. Because it's very scary, your body doing something that you're not in control of. So what I want to make the point of these patients who have psychogenic non-epileptic events, they are not kind of actively doing the event. Their body is having that reaction despite them trying to control it. So it's very, very scary for having, your body shake or some things happen when you feel like you're not in control. But once you're reassured and we explain what's going on and how these events can get better, sometimes that's kind of the only thing that's needed, and there's no further events. But sometimes if their underlying psychopathology is quite severe, medication treatment, for example, with antidepressants or anxiolytics is very, very important. We'll refer to all the patients to child psychologists. Now, I'm sure that everybody knows who's tried to find a psychologist to their child. It's unfortunately very, very limited resource. Sometimes just even school counselor or family counseling can be beneficial. Sometimes there's a hyper activities or attention deficits, treating that instead of depression. So not everybody needs to go on Prozac. It's kind of tweaking out what the underlying mechanism of psychopathology is there. And then kind of looking into stressors and emotions on these patients. It's really important. Multidisciplinary approach is really, really important. So not neurologists alone, or not psychologists alone or psychiatrists alone, but a combination of neurologists, psychologists, psychiatrists, pharmacologists, therapists, social worker. It's so important. So we're still kind of looking for that golden treatment group here as well. But that's kind of the goal that we try to reach. We try to get a good treatment team to the patient who has non-epileptic psychogenic seizures. There are multiple different kind of pamphlets out there. This is just something that I found useful. I often just either share the website or printing out to the parents, kind of just explaining what is it. And as I kind of pointed out earlier, prognosis in kids is better than adults. So majority of the pediatric patients, or at least half of them, will get better, like the events will resolve. And majority, like 80-90%, significantly improve after we make the appropriate diagnosis and proceed with appropriate treatment. The earlier we make the diagnosis, and if there's not a severe other psychiatric diagnosis associated with non-epileptic events, the better the outcome is. I want to share this patient with you in the end. So sometimes we actually see patients with, oh, that's that kid who has non-epileptic seizures. Oh, don't, let's not, start anti-epileptics or whatnot. So 19-year-old young man who's kind of known to the ER because mom brings him in because he has these episodes of screaming and kicking and hitting. Now, he does have some risk factors for epilepsy. For example, he was born prematurely. He had a few febrile seizures when he was young. And then he started having these episodes when he was around 10 years of age. Now, at one point, physicians were thinking, well, maybe these are epileptic seizures. Let's treat them with medications. But he had failed multiple anti-seizure medications. So kind of that, all that put together, the description of the events and the fact that anti-epileptic medications were not helping, he was thought to have non-epileptic seizures. I think he also had surface EEGs as well, and those had been normal. So, negative ED, you're failing multiple meds, and you have these episodes of screaming and kicking. So these are non-epileptic. Let's treat your underlying anxiety. You must be anxious. Go home, kind of a thing. And then we did a further evaluation, and there's also some key features on the events that we do. Often non-epileptic events, even though they often carry kind of similarities in that particular patient, they often still kind of differ look different from time to time, like different time of day, or they start a little bit differently, or maybe the left leg kind of jerks first, and then there's the right arm flailing, and then the body jerks a few times and whatnot. But what was kind of fascinating on this patient, his events, even though they look not seizure-like, they were always very stereotypical. I'm just going to show you the event on, again, I'm blocking his face with, so he screams very loudly, very, very strong kicking, hitting arms, flailing in the bed. That's our wonderful medical assistant who tried to calm him down. And then after the event is done, then he's like, oh my goodness, oops, I'm sorry. Oh my goodness, what happened? I don't know what happened. So this patient actually had frontal lobe seizures and underwent epilepsy surgery for treatment. So sometimes the events can look like they are not seizures, but they're epileptic. So that's why it's really, really important to make the correct diagnosis. So thank you so much for your support today and hanging out with me and hearing about non-epileptic seizures. If you have any questions or comments, I am here. And then you're welcome to either just send your questions in chat or not, or you're welcome to also go and enjoy the rest of your Tuesday. But thank you so much for showing up today. A very important topic to make the right diagnosis. Oh, you're welcome. Thank you. Yeah, so we do have, so the question is, can non-epileptic seizures happen with refractory epilepsy? So I feel like it's actually quite common. So we do have several patients who have documented, EEG documented medically refractory epilepsy. And anytime these patients start having new type of events that's not similar to their previous seizures, we'll always want to do an EEG to document what these new events are, because we do have several patients who carry both of the diagnosis. And that creates a challenge to the family, right? They're like, parents are like, well, how do we know then? Like, when do we go to the ER? When do we give the rescue medication? What do we do? And sometimes kind of we do the teaching to ourselves and to the parents in the hospital. They're like, well, you know, when Johnny turns his head to the right and extends her right arm and then does the lips back in, those are his epileptic seizures. But when the eyes roll around and then he kicks his legs and jumps off the bed, those are the non-epileptic seizures. So that's why it's kind of very important to get a detailed description. Like, we can't fall into the trap of, you know, this patient has epilepsy, oh, these events are seizures, let's increase the seizure medication. So we'll have to investigate every time, especially if the seizures look different or if the events look different than before. So absolutely, we can see a combination of them both. And sometimes it's actually more common of patients with epilepsy having also psychiatric comorbidities like depression or anxiety. So then we'll kind of have to look into that as well. And then when we address for example, get treatment for the depression or therapy for the depression and anxiety, then we can treat the epileptic seizures as well. So is it due to secondary gain from getting reduced stressors or recurrence placed on the child? So I personally don't think so. I think it's important to treat your child with epilepsy the same way as all of your other kids, or as you have the same demands and expectations to them. And then what I'm kind of hearing from that question is mom blames herself that maybe I didn't have the same expectations, so now my child can handle stress as well, so now they're having non-epileptic seizures. Don't blame yourself. That's not helpful. Every single person has different levels of I guess tolerance or kind of mechanisms of managing stress. So, some people are just more sensitive or vulnerable, or their kind of mind and body connection is different than others. So I wouldn't go into, somebody's weaker or doesn't have, good enough methods of managing stress. Whatever the level of that particular person is, then we'll deal with it. So the treatment is the same. If the non-epileptic seizures come from just stress to go into school versus stress to getting hit by a stranger on the street, kind of the treatment is still the same. So I wouldn't kind of make that link. Oh, I'm kind of pampering my child, so that's why they're having these events. I'm kind of always using that example of think about people react to stress differently. Like, for example, if you have to give a public talk or speech, some people get physical symptoms like migraine headache or stomach aches or even diarrhea as far as just anticipating that event. Or if you think about that, you have a lemon in your hand and you cut a slice of the lemon and you put the lemon piece in your mouth and you bite it. Just by thinking about it, at least my mouth, I get all saliva all over my mouth because I can taste that sourness in my mouth. So there's just a very, very strong mind and body function connection, and sometimes your body makes tricks on you because of the stress. So it's just kind of treating that underlying whatever's going on to help these events. Of course. Yeah, it's one of my favorite topics. I feel like sometimes there's no physicians who like treating patients with non-epileptic events, but it's really, really important to make the right diagnosis and take it seriously and treat it appropriately. We want these kids and adults to get better, so that's why it's really important. So thank you for listening. All right, everyone. Thank you so much for joining. Have a good Tuesday.